So let's run through the most important aspects of the anxiety and fear related disorders unit. Remember, this includes, ACEs can ask you questions about generalized anxiety disorder, about agoraphobia, and about what's called specific phobia. They're going to focus mostly on BII phobia, blood injection injury phobia. This is also how it's broken down in the ICD and the DSM. There are like particular phobias like agoraphobia that make it in there, and then there is just kind of a catch-all category of specific phobia. For diagnostic criteria, people experience excessive fear and anxiety, and it causes disturbances to their behavior. The symptoms, whether they're anxiety or phobias, need to be severe enough to cause significant impairment to one of those areas of psychosocial functioning. There's lots of ways to break it down. I do rows just because it helps me to remember. Relationships or family, occupation, social, like a social life outside of your family, and then educational. And then it's worth remembering the difference between fear and anxiety. We often use them kind of interchangeably, and in this unit, the importance is, or the distinction is important. A fear is a reaction to a perceived imminent threat in the present, like I am afraid. Anxiety, excuse me. Anxiety refers to a perceived anticipated threat in the future. So I can feel both. If, for example, I have a phobia of the dentist, which you know I do, when I'm in the dentist's office, right there waiting in the waiting room or in the chair, I'm feeling fear. I'm perceiving this as a threat in the present. But in the weeks leading up to my dentist appointment, I experienced bad anxiety, anticipating what might happen at it. We'll start with diagnosing generalized anxiety disorder. These are the characteristics from the ICD. I won't read them to you. I will just direct you to look at a couple of things. Remember, for some people, this manifests as excessive worry about something bad happening in several different areas of their life. But also for some people, I think the ICD calls it free floating. For some people, it's just like a general apprehension or worry that they aren't attaching to any certain areas, but they just feel. It's often accompanied by physiological symptoms like the ones there. Make sure you memorize a couple of those. And then, as always, it becomes clinical if it is causing that significant distress or impairment to one of those areas of psychosocial functioning. One of the ways that the generalized anxiety disorder is assessed is with something called the GAD-7. This is one of the measures they specifically mention or call out in the syllabus, so you need to be familiar with it. This is more of a screener. This is often used to refer on to a psychiatrist or a counselor. General practitioners, like doctors that they call GPs, what we would call like family doctors, in primary care may use it. A specialist is not going to use it to make a formal diagnosis. A specialist is likely going to use a clinical interview. There are 7 items. That's where the 7 comes from. They are scored on a 4-point scale, 0 to 3, referring to the frequency of occurrence of symptoms. So let's take a look at it. You can see it's specifically mentioning the frequency of events, and it's calls out the last 2 weeks. So over the last 2 weeks, how often have you been bothered by the following problems? Now, there are other measures of anxiety. There's also the Hamilton Anxiety Rating Scale, which you can see here. There's some crossover there. There's also Beck's Anxiety Inventory. So I don't want you to think that there aren't other measures. There certainly are. I don't know why ACE singles out the things it does, like the treatments or whatever that it does for us to put in the syllabus for us to learn about. But alas, the GAD-7 is the one that is there specifically for anxiety. When we talk about agoraphobia, agoraphobia is excessive fear or anxiety, again, fear or anxiety, in response to situations where escape might be difficult or help may be difficult to get. Public transport, being in crowds, anywhere outside the home, places where it might be difficult to escape or difficult to get help. They're often afraid of specific negative outcomes, such as panic attacks. I had you read the ICD on this topic, and you saw they were worried about panic attacks or fainting or incontinence or throwing up. So they anticipated these things might happen when they were out in public. In the case of agoraphobia, any of these places where escape might be difficult are actively avoided. They may be willing to like go out into a place like this, but they're going to endure that with extreme duress is the language they use, or they're only going to be willing to do it under very specific circumstances. And for a diagnosis to be made, the symptoms need to persist for several months. Culturally, one of the things that's mentioned is that if people live in a culture where most of their time is spent at home, it's understandable that they would feel kind of discomfort when they were in a crowded market. So you have to take culture into account. Or like if you're living in a place where violence is common, then to feel fear when leaving the safety of the home, it would not be clinical. That's not unreasonable. And like key to a fear is that it needs to be irrational. Women are twice as likely to develop agoraphobia compared to men. Then we have our specific phobia, that BII phobia. This is excessive fear, anxiety related to anticipation or exposure to a particular stimulus. Of course, as with all phobias, the fear needs to be disproportionate to the actual danger. The stimulus is going to be avoided where possible or endured with, again, intense fear or anxiety. They'll experience that extreme duress, and the symptoms need to persist for several months. So that's the characteristics, according to the ICD, of a specific phobia. When we get into blood phobia, one of the measures for that, the other measure that they want you to know, in addition to the GAD-7, is the BIPI, the Blood Injection Phobia Inventory. I'm very unclear as to why they chose this one, because there are many, many other ones, but here we are. This is the one that has those 18 situations involving blood and injections. There are 27 responses, some cognitive, some behavioral, and some physiological. And then the participants taking it will rate each of those responses on a scale of 0 to 3. So it's kind of hard to see, but over there on the left are the situations. If you take a look at them, you can see that they all relate in some way to blood injection or injury. And then over here, you'll see the cognitive responses, the physiological responses, and the behavioral responses. The actual thing has, you can see like a grid, and then they would rate each of these boxes would go a 0 to 3. This was like hard to see, so I tried to kind of reproduce it here so you could take a look at it. But this is what the BIPI kind of looks like. So a researcher called Mercedes Moss, seems to have written the BIPI and specifically wrote it so that there would be a validated measure of BII phobia in the Spanish language population. The study was originally published in Spanish. That's another reason it's a particularly interesting choice, because this is an example study that ACE gives us. But the goal was to write the BIPI, and in the study itself, I went through it and read it, and it shows like we originally had these 50 situations that we narrowed it down to these 18 based on like all of our research. So this study is really like her and her co-authors describing the process of creating this BIPI that they created and making sure that it was valid. So to see if the BIPI that they'd written could discriminate between those who had BII phobia and those without, and also to see whether it could identify, if it was sensitive enough a measure to identify a change as a result of therapy. They had 39 participants with BII phobia. They had a age and gender matched control group. They also had them take the fear questionnaire, another measure of phobias that's not specific to blood injection injury. And then their results were, the BIPI turned out to have excellent reliability and internal consistency. So if we remember, we talk about internal consistency sounds most like split half reliability, but also it had high concurrent validity with the fear questionnaire. So it seems like it is both a valid and reliable measure of blood injection injury phobia. And it also turned out to be a sensitive enough tool that it could identify therapeutic improvement. They actually did treat some of these patients and use the BIPI to try to track that improvement. Just as a reminder, because they often ask this question, so when you are evaluating the GAD-7 and the BIPI, I will leave that for you to look at, and we're going to talk about the explanations. Thankfully, there's only a few explanations here compared to, say, your OCD with 5, but we'll start with our genetic explanations. So one thing we know is that some phobias certainly do seem to be inherited, like BII phobia. Identical twins are more likely to both have the phobias than fraternal twins. The concordance rate for identical twins is higher. Heritability estimates seem to vary by the type of phobia, somewhere between 25 and 40%, some research suggests. It also seems likely that certain inherited personality traits make it more likely that you will develop a phobia. So you may not inherit your mom's blood phobia necessarily or flying phobia, but you're inheriting a personality trait, in this case, shyness or behavioral inhibition, being cautious in those new situations. And then because you're so cautious in those new situations, you're more likely to then develop a phobia. It seems like animal and like natural environment phobias show stronger genetic influence, while the situational ones like flying and elevators are less likely to be inherited and more likely to be learned. Of course, phobias, like most disorders, are polygenic. We haven't traced it to a single like blood phobia gene. It's interacting with environmental factors. Another example study is this one. This was the OST study. You can see there, this is just an example study. What I would want you to know about that is that they talked to 81 participants with blood phobia, 59 who had injection phobia, and then presumably your textbook describes it as like also other phobias, but this is their abstract, and this is what they say. So 81 participants with blood phobia, 59 with injection phobia. Did a clinical screening interview, a self-report questionnaire, had them talk about the impact on their lives, and what they found was that blood phobic patients were more likely to have a first-degree relative. 61% of them had a first-degree relative with the same phobia, compared to injection phobias, it was as low as 29. Blood phobic patients were also more likely to fear fainting compared to injection phobic patients. So there does appear to be a strong genetic link in blood phobia and a stronger physiological response. Now, if we talk about our behavioral explanation, we know that some phobias are acquired. They may be, some phobias may be inherited genetically, but some phobias are definitely learned through that process of classical conditioning. The Watson Little Albert example is a weird one because we don't set out to give people phobias. It is never going to be a deliberate attempt to give someone this kind of phobia. Now, phobias are formed. When you look at that, phobias can be formed very similarly to like trauma, but we've got a neutral stimulus, something that the person did not fear before, and it becomes paired either through multiple pairings or one very traumatic pairing. It becomes paired with an unconditioned stimulus. That is something that causes fear that you don't need to be taught to fear. Then because of that, because of those pairings, the neutral stimulus is now going to become a conditioned stimulus, something you have been taught or conditioned to fear, and it's going to provoke a response that is conditioned. So if we look at that breakdown, for Little Albert, the neutral stimulus was a white rat. Before Watson's experiment, the boy showed no fear towards it. But what Watson did was pair that neutral stimulus with these loud sounds. He would hit a steel bar with a hammer. That was an unconditioned stimulus, and it caused an unconditioned response. No one ever taught Little Albert to like fear that loud sound. It was a natural reflex. But when those two things were paired, now this neutral stimulus has really become a conditioned stimulus, and he's having a conditioned response to it. I'll let you look at the kind of session breakdown of Watson's procedure with Little Albert. Now, we know that phobias, many phobias are formed by classical conditioning, but they can also be maintained by operant conditioning, specifically that negative reinforcement. So whenever the participant or the patient avoids the phobic stimulus, the anxiety goes away temporarily. So that's where that negative comes from. It removes the anxiety. And what that does is reinforce that behavior. The behavior that caused it was avoidance. And by by canceling my dentist appointment or by crossing the street to get away from the dog, the anxiety temporarily goes away. And as a result of that, you feel more likely to reinforce that avoidance behavior. But we know that the only way to treat phobias is through systematic desensitization. So as long as you are avoiding it, your phobia is going to be continued or maintained. Now, I'll let you take a look at this, just a little bit of evaluation of Watson and that behavioral explanation, and then we'll talk about Freud. So as I'm sure you recall, Freud believed that our psyche was divided into three parts, and here are those three parts. And Freud also believed that we all went through certain psychosexual stages. And Freud in particular believed that during the phallic stage, people were likely to develop what he called an Oedipal complex. Now, if you look here, we talk about this one because for Freud, like there's the generic Freudian explanation, and then there's the explanation specific to little Hans, and little Hans is your example study. So your kind of generic Freudian explanation is that there's a conflict between the id and the superego. There is some kind of desire or inappropriate desire in the part of the id, and the superego is expressing guilt or like displeasure at that. So the ego makes the decision to displace that fear, whatever it is that they're feeling, to displace that or transfer it to something that feels safer. It makes the most sense in the context of little Hans. So Freud believed that all children, he was talking about little Hans, but all children would develop an inappropriate desire or sexual attraction for a parent, and then accompanying would be a hatred or fear of the other parent. The superego would express that disapproval. The ego would be trying to mediate between the two and defend itself, and it would displace or redirect or transfer the anxiety that was caused to a safer object or situation, something that they could avoid. And then by avoiding that phobic object, that would reduce the anxiety from that unconscious conflict. So in the case of little Hans, he had Oedipal feelings, he had attraction to his mother, and as a result of that, he experienced this fear and rivalry towards his father. According to Freud's reading of it, Hans felt guilty and he felt anxious about those forbidden impulses, but his superego repressed them. And instead of confronting his fear of his father directly, because that wouldn't feel safe, he projected that fear onto horses, especially the white horses with black nosebands. Not uncommon for Freud, in his rivalry with his father, he feared that his dad would castrate him. So this is why he specifically feared not just horses, but horses biting him. By fearing that horse, then Hans could avoid the conflict of fearing his father. It was a defense mechanism. It allowed him to avoid horses and avoid that fear and that anxiety. As is the issue with a lot of Freud's explanations and psychodynamic explanations, there's not always a lot of very solid evidence for it. At least with this one, we have the case of little Hans. But there's some issues, of course, with how Freud gathered that information about little Hans, and it's difficult to test in any way empirically. So something to be aware of. When we talk about our treatments, the treatments that are specifically mentioned in your A syllabus or called in your A syllabus, the behavioral therapy of systematic desensitization, and then also the psychological therapy of cognitive behavioral therapy, and specifically applied muscle tension. Now, there's a lot of crossover here because the systematic desensitization is the behavioral part, the part where you're doing those gradual exposures, but almost no treatment, including the key study with Chapman and DeLapp, almost no cognitive treatment for phobias doesn't include an element of exposure therapy. So it's a little awkward to break them out and list them out in this way. But when they ask about systematic desensitization, they're talking specifically about this part. The idea, of course, is that if the undesirable responses to the stimuli are learned, if you learned the phobia through classical conditioning, you can unlearn the phobia. We can make it so that once frightening stimulus goes back to being a neutral stimulus. This is based on the principle of reciprocal inhibition. The idea is that it's impossible to feel two strong opposing emotions simultaneously. So if we put the fear that we're experiencing from that phobic stimulus directly in conflict with deep feelings of relaxation and calm that we're fostering, it's going to be impossible for the fear and the anxiety to continue. So your procedure, as often, we're going to teach relaxation techniques. This may be muscle relaxation exercises, it might be visualization, or even sometimes anti-anxiety drugs. We're going to create an anxiety hierarchy with a series of phobic situations that increase in severity. And we're going to rate them using a subjective unit of distress scale. And then the patient is going to do a gradual exposure to each scenario, maybe in vitro or in vivo, maybe imagining them, maybe in VR or in vivo in real life. And this is that crucial part. The whole time they're going to be assisted by the therapist to remain in a calm, relaxed state. That's that reciprocal inhibition. Because as long as we maintain that calm, then that high anxiety can't get in. But of course, we're not going to move on to the next part of the fear hierarchy or anxiety hierarchy until the SUDS has dropped. Now, there are benefits, of course, to exposure therapy. There are also some cons, and you can see that if exposure therapy isn't for you, you can work on just that kind of cognitive restructuring element. You can just work on those thoughts, but not necessarily be ready to move on to that exposure therapy yet. Now, there's a particular therapy that's used along with CBT and along with systematic desensitization to treat T, the participant in the Chapman and Delap key study. I have a whole separate video about that key study, but it's worth reminding you of applied muscle tension. This is used specifically with BII phobia, and the goal of it is to prevent that physiological response, that fainting response that is more common with BII phobia than others. That allows the participant or the patient to actually engage in the therapy, because if they are fainting, then they're not going to be able to cognitive restructure or gradually expose. The fainting is caused by that there's a diphasic response with BII phobia. You have that sharp increase in blood pressure as a result of the anxiety of seeing the trigger, but then there's also that sudden drop, which is what causes the fainting, which you'll see in the study called vasovagal syncope. So the goal here is to increase the blood pressure and keep it higher before the exposure. You can see the procedure there, so I won't talk you through it, but then that was one part of the treatment that they used to treat T in Chapman and Delap.